At the outset, thank you, Dr. Moodley. I'm a little overwhelmed in being in a pediatric cornea session because I'm all glaucoma centric, and the only thing I do is when the cornea doesn't clear, I wish Moodley was there, but I end up doing more optical iridectomies than getting their PKs done. So the photographs of all these children have been displayed with consent, but then I always think in a presentation with children, it somehow gives us context when we show the babies that we're seeing. So the UBM has obviously been an invaluable asset to us, especially when we have a white cornea and we don't know what's going on underneath, and it has helped delineate what we are seeing. So when we need to look behind a hazy cornea for a glaucoma perspective, it also helps us decide an appropriate clinical approach. So this was, for instance, referred as corneal opacity following trauma. And on history, it turned out that she'd actually had an LSV for ROP elsewhere, and then had some subsequent trauma, but she came with these Harb's striae, and the presence of Harb's striae in a baby doesn't necessarily mean it is congenital glaucoma. It just means that the pressure has been elevated prior to it coming to us. And what we noticed was actually pupillary block glaucoma, and we did do a combined trab with trab, but I think what had worked in this was actually just the iridectomy and allowing the aqueous to come, and the other eye was completely normal. So this was interesting because we had this clear area in the center, and we thought it was Peters anomaly, but then on the UBM it showed us this huge intracorneal cleft. And so we started recognizing these intracorneal clefts as a really bad prognosticator for clearing. So when we have stromal separation in the cornea right at the beginning, we know it's not going to clear. But after glaucoma surgery, it's wonderful how it's remodeled, and there's only a little bit of the excavation of Peters anomaly that's there. And it did clear in the periphery enough, and we've done the iridectomy, but I guess these children should be also subjected to an OPK. But this has been a prognosticator in a sense, and we call them intracorneal clefts, but they do remodel very well. There are unusual cases. So this baby again came with trauma and actually a little bit of hyphema. And the parents, and something that looked like a worm-like thing in the eye, but when we did the UBM, again it showed us that the pupil was all right, and this iris was actually pulled right over the pupil. And all we did, the gonioscopy on table showed up these characteristic Axenfeld-Rieger processes, and all we did was with the vitrector just chip this little bit of iris there, and actually this baby next morning was fine and didn't have glaucoma at all. So sometimes this aberrant posterior embryotoxon can pull on your iris and come right over. And if we didn't have the UBM, we would have had no idea as to what is going on. And actually there was a little bit of iridodialysis, because of which there was a bleed. So this is something else very funny that we picked up in this white cornea. We thought it was acute hydrops, but with this big Descemet's tear, there was also a collection of fluid behind, and we wondered what this pocket was. So this is another thing that we found. It wasn't a cleft actually, but it was the small pocket of fluid, but that settled very well actually with surgery. So we have these funny things with glaucoma that we see, and the UBM has given us so many insights as to what is to be done. Well, when we see a newborn baby like this with a white cornea and a UBM like this, I think it is likely PCG, and I'm all right with this neonatal onset glaucoma, because something tells me that this is not going to clear very well because it's already white, but all this ground glass thing around is going to clear, and it's helped us prognosticate. And we can tell the parents that, look, she might have something central, but if you do the surgery in time, we might be able to salvage enough clear cornea to give some vision with an optical iridectomy. So in that sense, it's helped us once we have the UBM as part of our EUA. But when we see a diffuse haze, and again the UBM has helped us prognosticate, now if I see something like this and not exactly white, I'm pretty much sure that this baby is going to be good, because this is a huge cornea. This is almost 800 microns, but there is no white scar-like thing. And if they come early enough in the neonatal period without the stroma compacting, I sort of can say that this baby will do well, and they usually land up with, so if you do prompt CTT, they land up going to school and being normal children. But all white children are obviously not always PCG. This is something that we dread. If there's a posterior stromal defect along with a Descemet's defect, those are the ones where the central cornea is not going to heal. And it's not always just a Descemet's defect. It can be very, very large. And this intracorneal cleft is our bugbear. But we just go ahead and do as much as we can. And genetically, a lot of Peters anomaly that we see are CYP1B1. So they actually present with Peters on one side and PCG on the other. And I'm not even sure whether that semantic diagnosis is correct. We don't know that, but when we see a Descemet's defect, we still go along with the diagnosis of Peters. Sometimes the defect can be so big, so this looks like a cyst in the cornea, but since we had the UBM, we know that the entire lens is right there, and these eyes can be very, very tricky to treat and mostly don't have too much of visual potential, but we have a chance to treat the other eye. So how does it matter? For instance, if you didn't have a UBM and you didn't pick up the zonular cataract, on table you probably might think that it's a little bit of white, but if we didn't have this, we wouldn't have picked it up. And this has really spurred our rubella story, because now we think rubella, this needs cardiac evaluation, this needs a hearing assessment. And earlier, I can confess that a lot of children who were developmentally delayed, quote unquote, simply had a hearing loss, and it's just that we didn't think of it because we weren't looking for them. It also helps diagnose complex anterior segment dysgenesis. I learned this from Murli actually, not to go in at all, and we've recognized congenital primary aphakia, but the takeaway is that if you give them +14, +15 glasses, they are mobile, they are ambulatory, they can look into their phones, they have vision. So we used to give up on these with severe anterior segment dysgenesis, but the UBM has taught us to learn better. So when you have new toys, you want to play with them all the time. We know the AIOS2025 is a good non-contact device, but the swept source OCT has really been the game changer for us, because it takes 5 seconds to acquire an image. And when the retina guys can do their OCTs with the flying baby, we thought, well, why can't we do it on children? Now, this paper explains how to characterize the anterior segment OCT on the trabecular meshwork and the scleral spur. So we took this out of it and wondered if we could do it in children. And so we did our share of flying baby along with them and said, let's see what happens. So this is a garden variety PCG where I would do a GAT, 3 weeks old, nothing, the antenatal and postnatal history uneventful, everything else normal. And this diffuse haze with no stretching, but IOP is 12, CDR is 0.3, ultrasound normal. So all these come to us, and it's very, very difficult. We used to usually subject all of them to an EUA before we were sure that we maybe would not intervene and have another diagnosis. So we thought it's unlikely PCG, but what else? And is there any way to be sure? So this was possibly one of the earliest that we started imaging, and we were surprised that we actually could get very good images on the AIOS2025 in that 5 seconds with a swept source. And we could delineate the trabecular meshwork very well. We could delineate the insertion of the iris nicely on the ciliary body. And we had some way of saying that most likely our clinical suspicion is correct and it isn't really a glaucoma, because I can't see any evidence of angle dysgenesis. So we didn't do an EUA, but decided to go in for genetic testing instead, and sure enough, it turned out to be a congenital hereditary endothelial dystrophy. So we thought, okay, let's carry this forward and let's see our children with glaucoma and what it looks like. So this was the usual kind of child which I would want to do with unilateral PCG. That is something which is troubling me a lot, this unilateral PCG, because I really don't know what's going on. But you can see this trabecular meshwork clearly here, and the iris is here, and this is the normal eye. And here, there is no trabecular meshwork at all. It's a very deep anterior chamber, but there is no TM shadow. So this TM shadow is something which really stuck. And we did a few more. So this was another late onset PCG. the one thing that you notice is this is why there is a posterior bowing of the iris in these children, because as the eye grows, the iris is inserted way up, and then as the eye grows, it just falls back. So that's the reason why we see a lot of posterior iris bowing clinically when we do a gonioscopy. But the hallmark was there is no TM here either. So this is Axenfeld rigor, both eyes, and this is a very, very severe iris hypertrophy. Again, there is no TM shadow. So it looks like aniridia. Genetically, we've recognized that this is usually a FOXC1 deletion, which was erroneously called aniridia, but these are actually the deletions of Axenfeld. Early days yet, aniridia is another thing which is troubling me, because I don't know whether aniridia is just absence of iris or is aniridia a disease. Because we see a lot of absence of iris in severe iris hypoplasias, but they are not the PAC6 aniridia disease. So the 6-month-old child with aniridia, when we do an ASOCT, there's a stump in the iris, there is very little TM shadow visible, and we are very scared of doing anything to this baby, but then still there is some angle. This is a 6-year-old girl, and if you see, this iris stump is smaller and it's already getting on to wherever the trabecular meshwork should have been. Now this boy doesn't have glaucoma yet, this girl has glaucoma, but by the time this is a 13-year-old girl, and you can see the fundus shadows in this, when we did this, here you are, the iris stump has actually closed it. So it's helped in the sense that I would possibly do what David Walton called a prophylactic goniotomy in this, especially genetically, if this baby has the same variant as a parent does, because that's then PAC6 autosomal dominant aniridia. I would possibly do a goniotomy in this. I would do a combined trab with this, because I don't think there is much of a collector channel there. But for this, I would possibly go in and just do a tube majorly, because I don't think a trab will work in this at all. And I'd be scared with this iris stump closing it. So that's how it helped. We had open angles, and we went ahead and did a prophylactic goniotomy. What also helped, as I said, was he had exactly the same variant as his father, who had glaucoma. And you can see this cleft here. So that's why I said early days yet, because I don't know whether this is going to close. I don't know whether this boy is going to develop glaucoma, but I do know that the father with the same variant has very, very severe glaucoma, and I want to save this baby if I can. Whereas this girl with aniridia and advanced glaucoma and nystagmus with low vision and 28 and 30 millimeters pressures and superiorly subluxated clear lenses. I don't want to go in superiorly at all, and she also has a ptosis, so the only thing she's looking for from is inferior aphakic area. And that's how the lens is, and you can see the iris stump. So we planned against that and bilaterally just implanted a tube in the inferior sulcus, leaving the clear lens there, not touching it, and giving her aphakic correction. And we think this is possibly a better way to manage these children, but I hope we are right, because only time will tell. So it's helped in treating adult as well as childhood glaucoma, but it's given us more rational and informed choices of management. But still, technology we use as an ally, and as for all imaging, we can't use in isolation. Thank you.
Thank you, madam. That's excellent presentation.
And of course, I invite all my cornea, pediatric cornea colleagues to the IPGS and help us. It's in Madurai in December.
Yeah.